It's very rational to combine radiotherapy with immune treatment in general, and that is because radiation on itself has a strong immunological effect. The question is, if you combine this with radiation, with all the rationale, what is the toxicity? And we don't know too much about that, and that's the rationale in this study, to investigate this retrospectively in a quite small group of patients, a little bit less than 40, to look what is the toxicity by combining radiation with immune checkpoint inhibition. And of course it's a variety of radiation doses, volumes and so on, but still the authors do a very nice work showing that actually there's no increased side effects of radiation if you combine this with this type of intervention. Now we should be careful, of course, because again this was not prospective and we lack data on the details of radiation, that's to say the dose to a certain volume, so the technical aspects of radiation, what type of tissues were involved in detail, I mean, also the substructures of the tissue. And we should also bear in mind that in order to know the real side effects combining radiation with those immune checkpoint inhibition, we need prospective data, but also long-term data, not only about acute toxicity, but also about long-term toxicity. We know that in non-small cell lung cancer, like in small cell lung cancer, most patients with locally advanced disease are treated with a combination of chemotherapy and radiation, which is combined together, so-called concurrent regimen. But we know that the response and also the duration of the response is highly variable between individuals, and there's a hint that patients with specific mutations may have other response to chemoradiation than others. For instance, in a rather small group of patients, a little bit less than 60, they looked what is the influence of EGFR, ELK mutation, amongst others, on the disease-free survival of patients and the overall survival. Now, of course, there's only a small group of patients who bears these mutations, like always, and in that group, in this study, they showed, or at least they have the impression, that patients with an EGFR or the ELK mutation had a shorter progression-free survival, though the same overall survival as the whole group. Of course, this is a rather small group, retrospective, and it doesn't fit with the findings in brain metastasis that patients with EGFR mutated tumors have actually a better control with radiation, and it doesn't fit either in the observation, in vitro at least, that patients or tumors with an EGFR mutation have worse or decreased DNA repair. So I think that this study is the beginning. It should be enlarged. There should be more patients, and preferentially also with external validation sets. And on top of that, it should be corrected for other prognostic variables than the mutation alone. For instance, the volume of the tumor, the number of lymph nodes involved, because it may be just by an imbalance in prognostic factors that purely by chance that these findings were found.